Welcome back to the deep dive. This is where we take the most complex material out there and, well, we make it digestible, giving you those high-yield concepts you really need to know.
Today, we are jumping headfirst into one of the most intense areas in all of surgery trauma.
And not just any trauma.
No. Specifically, we're doing a full interpretation of Chapter 31 from the 28th edition of Baily and Love's Surgery. We're talking about maxillofacial trauma. This is very demanding stuff.
It really is. I mean, maxillofacial trauma feels unique because it's this perfect storm, isn't it? You have the immediate life-threatening ABCs of any major trauma.
Right.
But it's combined with this incredibly complex, intricate anatomy. Anatomy that affects, how you see, how you speak, your entire identity, really.
That's the core challenge. And for anyone revising this or, preparing for an emergency assessment, the sheer volume of detail can just feel paralyzing.
Absolutely.
I think the biggest hurdle for a learner isn't that the material is impossibly difficult, it's the speed. It's the speed at which you have to process all of this information when you are under immense pressure.
So that's our mission today.
Exactly. Our mission is to take this critical chapter and turn it into a system for you. We want to give you mental anchors, the sort of ready reckoner for revision.
A framework.
A framework, yes. But, and this is crucial, this is our interpretation. It is designed to be used alongside the textbook, to supplement it, never to replace it. You have to go back to the source.
Of course. Think of this deep dive as us building the scaffolding for your understanding. We're going to give you those conceptual hooks, those anchors we mentioned.
So that when you're faced with a patient and their face is severely disrupted, you don't freeze.
You'll have a sequence, you'll know the critical steps of assessment and intervention, and hopefully you won't feel so overwhelmed.
Right. So let's jump in. Let's start with that non-negotiable standard the second that patient comes through the door.
Okay, so let's unpack the reality here. The mechanisms for maxillofacial injury. They're pretty common, right? Road traffic accidents, interpersonal violence.
Yes, RTAs, which mean high velocity. Fights, which are often focused, blunt force. Sports injuries, simple falls. But the cause, at least initially, doesn't matter.
That doesn't change the first step.
It doesn't change the first step. The core principle is rigid. We do not start with the face. It might be the most dramatic injury, the most visually arresting, but you ignore it.
So this is pure advanced trauma life support, ATLS protocol.
100%. Any patient with any degree of facial injury demands immediate, strict adherence to the ATLS primary survey. That's airway, breathing, and circulation, the ABCs, with simultaneous concurrent cervical spine protection.
You cannot let the visual distraction of a mangled face pull you away from what's actually going to kill the patient in the next few minutes.
You can't. That's the discipline.
So we've gone through the primary survey. We've got the team working on ABC. Now we can start to think a little about history. What are the key details we're looking for?
This is the detective work. You want to characterize the energy transfer. Was it a sharp object or blunt force? Was the wound contaminated? Think road grit, dirt. Was it high impact, suggesting other injuries, or was it localized?
And their general medical history too, I assume?
Quickly, yes. Allergies, medications, any chronic illnesses. And critically, if there's any chance of contamination, you need to know their tetanus status.
But all of this is secondary to one thing.
All of it is secondary to the airway.
And that brings us to what you called the maxillofacial airway nightmare. Why is this so fundamentally different from, say, a standard trauma airway? Why is it often so much harder?
Because the very framework, the bony structure holding the upper airway open, can literally collapse. And this is our first huge mental anchor for you to hold on to, the mid-face collapse anchor.
Tell me more about that. What is physically collapsing?
Okay, imagine a severe blow high on the mid-face. The classic example is a dashboard injury in a high-speed crash without a seatbelt or a really severe punch.
A huge amount of force.
A huge amount of force. That force can fracture the attachments, the pillars that hold the maxilla, the upper jaw, to the base of the skull.
So it just shears off.
It shears off, and when the maxilla detaches, it gets displaced downwards, and this is a critical part, backwards. All the support for the space behind your nose and in your throat, the pharyngeal space, is just gone.
I see the Jenga tower analogy from the chapter now. The bony tower has collapsed inward.
Yes. And all the soft tissues that it was holding taut, the palate, the back of the nose, are now loose, displaced, and falling back into the airway.
And this initial collapse is just the beginning of the problem.
Exactly. That impaction is immediately compounded. Let's say the patient also has a bilateral mandibular fracture. So the lower jaw is broken on both sides.
Right.
The muscles that hold the tongue forward, like the genioglossus, are now attached to floppy, unstable pieces of bone. The tongue has lost its anchor, so it has nowhere to go but backwards.
So now you have the collapsed maxilla and the tongue blocking the airway.
A literal mechanical obstruction. And then you add the body's own response to trauma.
Swelling. Massive edema.
Right. Figure 31.2 in the text shows it perfectly. You get severe swelling of the soft palate and the tongue itself, and that starts to rapidly choke off whatever tiny bit of pharyngeal space is left. It's a perfect storm for total airway obstruction.
That paints a terrifying picture. It makes the urgency absolute. So if we see a patient with stridor, they're in distress, their GCS is dropping, what is the immediate hands-on thing we do before we even reach for an ET tube?
These are the immediate airway relief techniques. And for the obtunded or unconscious patient, you have to try to manually disimpact the maxilla.
What does that mean? What do you physically do?
You put your fingers inside their mouth, behind the soft palate, and you physically forcefully pull the entire facial skeleton forwards.
They're pulling the whole midface forward.
You are literally reversing the impaction, restoring some of that bony support, and hopefully opening up that posterior pharyngeal space. It's a powerful, hands-on maneuver.
And what if the tongue is the main problem?
If the tongue is falling back, you need to get immediate physical control of it. This is often done with a large suture, a stitch passed right through the front part of the tongue.
Or even a towel clip, the text says.
Or even a towel clip, yes. Anything to allow you to pull it forward and anchor it, maybe even to the chin, just to keep it out of the airway.
And on top of all this, the environment is just a mess.
It's a mess. It's full of blood, saliva, broken bits of teeth, bone fragments. So high volume suction must be on, operational, and right there in your hand. You have to constantly clear that airway because all of that debris is a massive aspiration hazard.
So you're not just stabilizing, you're constantly cleaning. Once you've done these manual things, what's the definitive goal?
The definitive goal is secure control. The team has to be ready for endotracheal intubation. But, and this is a big but, if the facial distortion, the swelling, the massive bleeding makes that impossible.
A classic difficult airway scenario.
A very difficult airway. You have to be ready to pivot immediately to a surgical option. That could be a needle cricothyroidotomy as a temporary fix, or an emergency surgical airway, which usually means a formal tracheostomy.
And figure 31.3 in the source material, showing that patient with a tracheostomy, it's a reminder that this is not a rare intervention. This is often required.
It's a reality of this kind of trauma.
Okay, moving from A for airway to C for circulation. Let's talk about catastrophic hemorrhage. The amount of bleeding can seem totally disproportionate to just a facial cut. Where is it all coming from?
The bleeding is often deep, and it's often arterial. In midface damage, the two big culprits are the maxillary artery, which is tucked away deep inside the pterygopalatine fossa.
A very protected space.
Very protected until the whole structure shatters. Or it's the pterygoid venous plexus, which is this incredibly vascular network of veins.
And in penetrating injuries.
In penetrating injuries to the lower face or neck, then you're worried about branches of the external carotid artery or the tributaries of the internal jugular vein. Much bigger vessels.
I want to focus on that pterygoid venous plexus for a second. We think of arterial bleeding as the scariest, but venous bleeding can be just as bad, can't it?
It can be catastrophic.
Yeah.
The problem with the pterygoid plexus is that it's a low-pressure but very high-volume system of veins, and it's encased in bone.
So you can't compress it.
You can't. When the bone shatters, the vessels tear, and it just pours. It's not pulsatile like an artery. It's a constant high-volume flow of dark venous blood that fills the pharynx and threatens that already fragile airway.
So if you can't clamp it, if direct surgical control isn't an option in the emergency room, the control methods are all about pressure.
All about pressure. Direct digital pressure for anything you can see and reach. But for that deep midface and nasal bleeding, we have to rely on packing, anterior and posterior nasal packing.
You're essentially creating an internal tamponade.
That's exactly what it is. You can use specific inflatable balloon packs that are designed for this, that expand and put pressure on the whole nasal cavity. Or, and this is a brilliant field expedient mentioned in the chapter, you can use a Foley urinary catheter.
A Foley catheter? How on earth does that work?
It's incredibly effective. You pass the Foley through the nostril until you can see the tip in the back of the throat, the nasopharynx.
Okay.
Then you pull it back slightly so the balloon is snug behind the soft palate, and then you inflate the balloon with saline.
Ah, so that becomes your posterior anchor.
It becomes your firm posterior pack. It occludes the bleeding from back there and gives you a solid wall to pack the anterior nasal cavity against. It provides crucial, temporary control of what could be a fatal hemorrhage.
That's a great clinical tip. But we also have to think about the secondary airway concerns, the things that happen after the initial injury.
Yes, the intervention itself can threaten the airway. The sheer amount of soft tissue swelling that develops over the first few hours can be astounding,
Or the swelling from the surgery later on.
or the swelling from the surgical manipulation. This might mean you have to make a decision to preemptively intubate the patient or even perform a tracheostomy to secure a patent airway before the swelling makes it impossible.
Now we have to address the hidden killers, the immediate threats to life and sight that can be masked by everything else that's going on. Let's start with the brain.
The masked head injury. This is incredibly common, especially in trauma from violence. Patients are often intoxicated, either with alcohol or drugs.
And that means their neurological exam is unreliable.
Completely unreliable. They can't tell you if they have a headache, if they're nauseous, if their thinking is fuzzy. Intoxication completely masks the symptoms of what could be a very serious cerebral injury, like a bleed.
So given that unreliability, what is the clinical action point? What must you do?
You must operate with a profoundly low threshold for ordering a brain CT scan.
A low threshold.
A very low threshold. If the mechanism was high energy, if the patient's GCS is fluctuating or just unreliable, you get the CT. No hesitation. And a practical point. When you order it, ask for the scan to include the facial bones as well. That prevents having to send the patient back for a second scan later.
Good tip. And the second immediate threat is to sight. Orbital damage is common with these midface injuries.
And we have to specifically actively screen for retrobulbar hemorrhage. This is a critical, time-sensitive diagnosis.
Emergency.
A true surgical emergency. Bleeding behind the eyeball causes acute pressure to build up inside the orbit. That pressure compresses the optic nerve and chokes off the blood flow from the retinal artery. If you don't intervene, it leads to permanent, irreversible blindness. It's a ticking clock. We'll talk more about how to deal with it in Section 5.
Okay, a powerful and detailed opening. I think it's time for our first conceptual check-in.
All right, check-in. Question 1. You have a patient who is unconscious after a severe blow to the midface. Their airway is audibly compromised. It seems like a mechanical obstruction. What are the 2 immediate non-surgical maneuvers you must perform while your team is getting ready for a definitive airway? Think about the bone and the tongue. Okay, the 2 maneuvers are, 1, manually disimpacting the maxilla, that's pulling the midface forwards with your fingers, and 2, controlling the tongue, either with a large suture or a towel clip to stop it from falling backwards. If you couldn't recall both of those, just rewind and listen to Section 1.2 again. It's that important.
All right, so our key takeaways for this first section, in summary. ABC assessment is mandatory, always with C-spine protection. The maxillofacial airway nightmare is real, caused by midface collapse and tongue displacement.
Catastrophic bleeding, often from that deep pterygoid plexus, is managed with pressure and internal packing, like that Foley catheter trick.
And finally, those masked life and sight-threatening injuries, the head injury and retrobulbar hemorrhage, require an immediate low-threshold approach to investigation and treatment.
So, once the patient is stabilized, we can move into the secondary survey and start to classify the damage in a structured way. This systematic approach is like learning the language of the injury, so everyone on the team is speaking the same language.
All right, let's start with classifying bony injuries. The chapter breaks them down by type, which is really useful because the type tells you about contamination risk and how complex the repair might be.
Exactly. So you have a simple fracture, which is just a single clean break. Then you have a compound fracture, which is critical because it communicates with the outside world, either the skin or, more commonly, the oral or nasal mucosa.
Which immediately means a higher risk of infection.
Immediately. Then you have comminuted, which means the bone is in multiple fragments, like it's been shattered. That often means a more complex load-bearing fixation is needed. And complicated, which means a nearby nerve or blood vessel has been damaged as well.
There are also a couple of specific types. Green stick.
Green stick is where only one cortex of the bone breaks. You see that in younger patients whose bones are more pliable, they bend before they snap completely. And then you have pathological fractures, which is a breakthrough bone that was already weakened by something else, like a cyst or a tumor.
Beyond the type, we also classify by displacement.
Yes, and this is really the fork in the road for management. Is the fracture undisplaced, minimally displaced, or displaced. That's what decides whether we can manage it conservatively or if we need to go to the operating room.
To make sense of all this, to map it out on the face, the source uses a great spatial classification, the rule of thirds.
It's a simple and effective way to think about it. Vertically, the face is split into 3 zones. The upper face is from the level of the corners of the eyes upwards, so the frontal bone, the frontal sinuses.
The lower face is easy, that's just the mandible and the lower teeth.
Right, and the really complex area is the midface. That's everything from the upper teeth up to the level of the canthi.
And the midface is so intricate, it gets its own subdivision.
It does. We split it into the central midface, which is the very delicate naso-orbital ethmoidal complex, the NOE, and the lateral midface, which is the much more robust zygomatico-maxillary complex, or ZMC. This helps you focus on what specific structures are at risk.
We touched on the most severe fracture types earlier. Let's talk about craniofacial fractures. What makes these so much more complex?
The complexity bar jumps way up because now you have a direct communication between the facial skeleton and the dura, the covering of the brain. Any tear there means a CSF leak and a massive risk of meningitis.
So when we classify frontal sinus fractures, we're really classifying the risk to the brain.
Precisely. We look at whether it's the anterior table, which is more of a cosmetic problem, the posterior table, which is an intracranial problem, and whether the frontonasal duct, the sinus's drainage pipe, is damaged.
And the absolute hallmark of high-force injury is the panfacial fracture.
Yes. This means there's trauma to all 3 facial thirds. It implies an incredible amount of energy transfer. If you see a panfacial fracture, you have to assume there are other serious injuries: head, chest, abdomen, until proven otherwise.
Okay, let's shift to soft tissue injuries. The classification here is more about depth and communication, right?
It is. Lacerations are described by the instrument. A blunt crushing force gives you ragged, bruised edges, whereas a sharp object gives you a clean, incised wound. But the most important distinction for you to make is the through-and-through wound.
And that's one that communicates from the skin all the way into the mouth or nose.
Exactly. These are, by definition, heavily contaminated. They need meticulous cleaning, a careful layered closure, and almost always antibiotic prophylaxis.
And before you even think about stitching it up, you have to look deeper.
Always. You must assess for tissue loss. Do you need a flap or a graft? And most importantly, you have to rule out damage to the underlying structures: the facial nerve, the infraorbital or mental nerves, and the parotid duct.
So let's just recap the clinical assessment. We've talked about the primary survey, but gathering that history concurrently is so important. Why?
Because it guides your index of suspicion. If you know the injury was high velocity, you start thinking about bony fragmentation and dural tears. If you know it's heavily contaminated, you're thinking about infection risk and tetanus. It helps you look for the occult injuries, the ones that aren't immediately obvious.
We've covered the primary survey: bleeding, circulation, GCS, C-spine control. In that initial phase, we're told to remove large, obvious foreign bodies. But the chapter gives a huge warning about penetrating objects.
And this is critical advice for anyone, especially a junior clinician. If you have a penetrating fragment, a piece of glass, a blade, part of a weapon, and it's anywhere near deep structures like the carotid artery, the brain, major nerves, you do not remove it at the bedside.
Why not?
Because that object might be tamponating a catastrophic bleed. The second you pull it out, the patient could exsanguinate. Removal only happens in the controlled environment of the operating theater, with surgeons and equipment ready, and only after you've got detailed imaging.
Okay, the secondary survey. The chapter is really strict about a top-down approach. Why is that systematic grid so much better than just looking at the most painful spot?
Because it prevents tunnel vision. The visual horror of a facial injury can be so distracting that you miss other things. By forcing yourself to go systematically scalp, neck, ears, frontal view, and so on, you ensure completeness. And that's especially important for the next area, the cervical spine.
You look more about the C-spine risk.
It's so easy to miss a concurrent spinal injury. The facial pain is overwhelming and it distracts the patient and the clinician. But if they took a high-energy blow to the face, you have to assume that force was transmitted to the neck. You must maintain full C-spine precautions until it's cleared radiologically.
The second big challenge is the eye exam. The patient is swollen shut, they can't open their eyes. What do you do?
An inadequate assessment of the orbit is a failure of care. It's difficult, but it's not impossible. You have to assess the key components. Globe position, is it bulging or sunken? Visual acuity, can they even see light? Diplopia, are they seeing double? And eye motility, can they move their eyes?
So how do you physically get past that swelling? What's the technique?
The chapter gives you that crucial clinical pearl. You apply gentle, steady pressure on the eyelids to temporarily squeeze out some of the edema. Then you use a piece of dry gauze or cotton swab to gently pull the eyelids apart. It might only give you a few seconds, but it's enough to see the globe, check the pupil, and assess movement.
Then we move to palpation, our palpation anchor. We're feeling for a step, deformity, tenderness, asymmetry. Where do we focus?
Again, be systematic. Follow the bony framework. Start high at the supraorbital ridge and the lateral orbital wall. Move down to the inferior orbital rim and the prominence of the cheekbone, the zygoma. Then check the nasal bones, and finally the whole lower jaw, running a finger up into the TMJ area and along the entire mandible.
Finally, the oral cavity and dental examination.
Right.
You said earlier that the patient often gives you the biggest clue themselves.
They absolutely do. They will complain that their occlusion feels altered, their bite feels funny or off. This is the single most important clinical sign of a displaced mandibular or maxillary fracture. Patients can detect a shift of less than a millimeter that you might not see on an X-ray.
What else are we looking for inside the mouth?
Specifically for mandibular fractures, you're looking for torn mucosa, which tells you the fracture is compound. You look for a hematoma, a deep bruise in the floor of the mouth. That's a very strong sign of a fracture. And you're testing sensation in the lower lip and chin.
Looking for that nerve damage.
Yes, checking for altered sensation, paresthesia from damage to the inferior alveolar or mental nerve.
Yeah, we cannot forget teeth accountability. This is a real aspiration risk.
A huge risk. Every single missing tooth or fragment of tooth must be accounted for. Did it fall out onto the ground? Is it just displaced? Is it fractured? If you don't know where it is, especially a fragment, you have to assume it could have been aspirated into the lungs.
Which means?
Which means a chest radiograph must be considered to rule it out.
Okay, time for our second check-in, focusing on that systematic approach.
Case study prompt 2. A 40-year-old patient comes in after a fall. They can't open their eyes because of severe swelling. They keep saying, "My bite just feels funny." What is the single most important assessment you must perform immediately, and what potential neurological deficit do you need to specifically look for inside their mouth?
Pause.
Okay, the single most important assessment is the globe, the orbit. You have to exclude a vision-threatening injury, and you do that by gently pulling the eyelids apart. The neurological deficit to check for is that altered sensation paresthesia in the lower lip and chin, which points to inferior alveolar or mental nerve damage from a mandibular fracture.
Great. So the key takeaways for Section 2 are: classification is by type and facial thirds. The systematic top-down secondary survey is non-negotiable, with special attention to the C-spine.
The orbit must be assessed, even if you have to physically overcome the swelling. And remember that altered occlusion is the key diagnostic feature of a displaced fracture. So we've done our clinical assessment, we have our suspicions. Now we need imaging to confirm them. And while CT is king, specific plain X-rays are still the workhorse for screening, especially for the mandible.
Right, let's nail this down. For imaging the facial skeleton, if you suspect a mandibular fracture, you need 2 views at right angles. What are they?
The standard pair is an orthopantomogram, or OPT. It's that panoramic X-ray you get at the dentist. It's great because it flattens out the whole curved mandible onto one film, so you see both sides, the condyles, the teeth, everything.
In the second view.
A posterior, or PA, radiograph of the mandible. This shows you any medial or lateral displacement, which the OPT can sometimes miss. It's the view at a right angle.
And what about for the midface?
For a suspected midface fracture, the classic views are occipitomental, or OM, radiographs. They're taken at 10 and 30 degrees. The trick with the OM view is that it projects the dense petrous bones of the skull downwards, out of the way of the midface structures.
So you get a clearer view of the orbits, the zygomatic arches, and the maxillary sinuses.
Exactly. But if any of this imaging suggests a complex injury or a high-force mechanism, we immediately pivot to the gold standard.
The CT scan.
The CT scan of the facial bones. It gives you unparalleled detail. And for complex orbital or panfacial fractures, we use 3-dimensional 3D reformatting. It gives the surgeon a perfect roadmap for planning the operation. And again, if you have any suspicion of a head injury, the brain CT has to be included.
Okay, let's focus now on mandibular fractures. The chapter highlights 3 classic weak points in the mandible.
Yes. Based on biomechanics, there are 3 common sites for fractures. Number 1, the neck of the condyle, which is the thin part just below the jaw joint. It acts like a crumple zone. Number 2, the angle of the mandible, which is often weakened by the presence of an unerupted or impacted third molar, a wisdom tooth. And number 3, the region of the mental foramen, which is a natural hole where the nerve exits, creating a weak spot.
And what's fascinating is that these fractures rarely happen in isolation.
That's the biomechanical truth of it. The jaw is a ring. If you apply force to one part of the ring, say the chin,
The force gets transmitted around the ring.
exactly, it creates tension on the opposite side, often causing a second reciprocal fracture. So a classic pattern is a fracture on the chin, the parasymphysis, paired with a fracture on the contralateral, the opposite angle or condyle. The takeaway is always look for the second fracture.
And we have to come back to the nerve anchor here, the inferior alveolar nerve. If the patient has numbness in their chin, does that change the management?
It changes our urgency and how we counsel the patient. They need to understand that the sensation might take months to recover, and sometimes it's incomplete. It doesn't necessarily mean you have to rush to surgery. The nerve often runs right through the fracture line anyway, but it gives you a baseline to monitor. And reducing the fracture with ORAF might help decompress the nerve.
So let's talk about that definitive treatment. When is open reduction and internal fixation, or RIF, the right call?
ORAF is the standard of care for most displaced mandibular fractures. You surgically expose the fracture, put the pieces back together anatomically, that's the open reduction, and then you fix them in place with titanium minute plates and screws. That's the internal fixation.
And timing is important.
Ideally, you want to do this within 24 to 48 hours. It minimizes swelling, reduces the risk of infection, and lets the patient get back to function much faster. And because of the communication with the mouth, postoperative IV antibiotics are standard.
What if the fracture is undisplaced? We manage it conservatively. But what does failure of conservative management look like?
Conservative management is basically antibiotics, pain relief, and a non-chewing soft diet for about 4 weeks. Failure is indicated by 2 key signs: increasing pain, which suggests movement or infection at the fracture site,
Or that key sign again.
or a change in their occlusion. If the patient suddenly says their bite feels worse or different, that means the fracture has displaced, and now they need an ORF.
This brings us to a really important surgical concept: fixation mechanics. The difference between load-sharing and load-bearing plates. Explain the biomechanics here.
This is all about how stable we need our fixation to be. For a simple fracture that you can reduce perfectly where the bone ends butt up against each other nicely, you can use load-sharing fixation.
So the plate and the bone are working together.
Exactly. You use smaller plates with monocortical screws, and the plate shares the mechanical load of chewing with the well-lying bone, which is still providing most of the strength.
So when do you need load-bearing fixation?
You need load-bearing fixation when the bone itself can't bear any load. So in a complex, comminuted fracture with lots of little pieces, or if there's a gap of missing bone, here, the plate has to do all the work.
So you use much bigger, stronger plates?
Much heavier reconstruction plates with bicortical screws that go through both cortices of the bone for maximum strength. The plate is essentially acting as a bridge.
The placement of these plates is also really specific. The 2-plate anchor in the pin is a great example. Why 2 plates there, but often only one at the angle of the jaw?
It's all about resisting muscle pull. At the angle of the mandible, the big chewing muscles mostly create tension and compression forces. So you can place a single plate along the line of maximal tension, usually near the top border, and that counteracts it.
But the chin is different.
The chin is different. The muscles in the front and the forces of biting create significant torsional or twisting forces. To resist that twisting, a single plate isn't enough. You need 2 smaller plates placed about 5 millimeters apart to act like struts and prevent that rotation.
And getting those plates on at the angle can be tricky. What's the approach mentioned in the text?
For angle fractures, it's hard to get good access from inside the mouth, so a transbuccal approach is often used. It's a tiny incision in the cheek that lets the surgeon use a special guide, a trocar, to place the screws perfectly perpendicular to the bone. It gives great fixation without having to strip all the soft tissue away inside.
Now let's move up to condylar fracture management. You said most are treated conservatively, but that seems to be changing. What are the things that would push you towards surgery, towards an ORF for a condyle?
You're right. The trend is moving more towards ORF. While closed reduction with elastics and a soft diet is still fine for most minimally displaced condyles, surgery is indicated when there's significant displacement that causes a loss of mandibular height.
Which would mess up the bite.
Exactly, it causes a severe open bite. Or when the displacement is so bad, it's physically stopping the jaw from working properly. Restoring that condylar height is crucial for the long-term health of the TMJ.
And if you do decide to operate, the access is really challenging because of the facial nerve.
It's notoriously difficult. The traditional approach is through a retromandibular incision, carefully dissecting through the parotid gland to avoid the facial nerve branches. But more and more specialist units are using endoscopic-assisted fixation to do it with smaller incisions and better visualization.
What if you have a patient with a badly displaced fracture, but they're too unstable for surgery right now, or the OR is just not available? Is there a temporary fix?
There is. It's called a bridle wire. It's basically a wire placed around the teeth on either side of the fracture line. It doesn't fix it, but it pulls the main fragments into a better alignment. It can significantly reduce pain, control mobility, and let the patient eat and drink something until they can get to the theater for their definitive ORIF.
All right, time for check-in 3.
Case study prompt 3. A 22-year-old cyclist comes in after a high-velocity crash. He landed on his chin and has a displaced fracture at the parasymphysis. Based on your knowledge of mandibular biomechanics, where must the surgical team absolutely look for a second fracture? And what specific type and number of plates will likely be needed for his chin fracture?
Pause.
Okay, so with a parasymphyseal fracture, the team must look for a second contralateral fracture, most likely at the condyle or the angle. The chin fracture itself will require 2 plates, placed 5 millimeters apart, to resist those torsional forces. It will likely be a load-sharing construct, assuming the fracture can be well reduced.
Key takeaways for section 3. Imaging for the mandible requires an OPT and a PA view. Always look for the second reciprocal fracture.
Most displaced fractures are treated with ORF within 48 hours, and the choice of fixation is dictated by the fracture pattern. Is it load-sharing for a simple fracture, or load-bearing for a complex one?
Okay, let's move up now into the really intricate midface puzzle, starting with the zygomatic bone, the cheekbone. This is usually from direct, blunt trauma, right?
Exactly. It's a very common isolated facial fracture, and the zyoma is so important. It gives the cheek its projection, it protects the eye, it forms part of the socket. To understand its stability, we use our next anchor, the 4-legged stool anchor.
Okay, walk me through those 4 legs again.
You can visualize the zygoma being held in place by 4 struts or legs. Leg 1 is the zygomatic arch bowing back towards the ear. Leg 2 is its connection to the frontal bone at the frontozygomatic FZ suture.
Okay.
Leg 3 is the infraorbital rim, the bottom edge of the eye socket. And leg 4 is the maxillary buttress, which connects it down to the maxilla. The bone usually fractures at or near these 4 points.
Clinically, there's going to be massive swelling. So what are the reliable signs that specifically point to a zygomatic fracture?
The swelling and bruising around the eye are a given, but the 2 specific signs are, 1, feeling a distinct step deformity when you palpate the orbital rim or the arch, and 2, seeing a subconjunctival hemorrhage, a bleed on the white of the eye that has no visible posterior border.
What does that mean, no posterior border?
It means the blood just fades away towards the back of the eye. It tells you the bleeding is coming from deep within the orbit, which implies the orbital floor or walls, part of the zygomatic complex, are broken, and you must get a CT scan to confirm that and rule out other orbital injuries.
You mentioned before that the definitive assessment for these often has to be delayed. Why can't you just decide on surgery right away?
Because the initial edema is so massive, it completely hides the true cosmetic deformity. The source specifically advises reviewing the patient about a week later.
After the swelling has gone down.
After the swelling has subsided, only then can you accurately assess the asymmetry, the loss of cheek projection, and any functional problems.
So that patient comes back in a week. What are the key indications for surgery? When do you operate on a broken cheekbone?
Well, if it's undisplaced, you just manage it conservatively soft diet, avoid pressure for a few weeks. But you operate for significant cosmetic changes like a flattened or asymmetrical cheekbone, persistent eye symptoms, especially diplopia, double vision, any obvious orbital deformity, or, and this is a key functional one, restricted mouth opening.
Why would a broken cheekbone stop you from opening your mouth?
Because the depressed zygomatic arch can physically impinge on the coronoid process of the mandible, blocking its movement.
Okay. Let's talk about the reduction techniques. The text mentions closed techniques like the Gillies lift.
They're still used for simple, isolated arch fractures. The Gillies lift involves an incision in the temple and the hairline, and you pass an elevator underneath to pop the arch back out. Keen's technique is similar, but through an incision inside the mouth.
But for anything more complex, it's ORIF.
For anything unstable or comminuted, yes. It's ORIF with small, low-profile 1.5 millimeter titanium plates at the fracture sites. The FZ suture, the infraorbital rim, the buttress, and depending on how unstable it is, you might use 1, 2, 3, or even 4 plates.
Now for the maxilla and the classic historical Lefort classification. We know they rarely present as clean breaks, but understanding the fracture lines is key to understanding the repair.
It is. René Lefort did these original experiments on cadavers, mapping the predictable lines of weakness in the facial skeleton. The anchor here for you is to understand that each level, from eye to third, represents a higher and more severe separation of the midface from the skull base.
Okay, so let's start at the bottom, Lefort first.
Lefort the first is the floating palate. It's a horizontal fracture that separates the entire tooth-bearing part of the maxilla, the palate, and the alveolar ridge from the rest of the face. The fracture line runs through the piriform aperture of the nose, the walls of the maxillary sinus, and breaks the pterygoid plates at the back.
And clinically, the patient's entire upper jaw will be mobile.
You can physically move it.
Okay, next step, Lefort the second.
Lefort 2 is the pyramidal fracture. This one goes higher and includes the nasal bones. The fracture line still starts at the pterygoid plates, but then it runs across the inferior orbital rims and meets at the bridge of the nose. So the whole central part of the face, shaped like a pyramid, moves as a single unit.
More force, more structures involved. And the most catastrophic is Lefort 3.
Lefort 3 is craniofacial disjunction. This is the ultimate separation. The entire midface skeleton, the maxilla, both zygomas, the nasal complex, is completely detached from the base of the skull. The fracture line runs through the pterygoid plates, the zygomatic arches, the lateral orbital walls, the FZ sutures, and across the nasal bridge. This is the definition of that Jenga tower collapse we talked about at the start.
So for management of these maxillary fractures, if they're mobile or the bite is off, OIF is needed. Where do you put the plates to fix them?
You have to anchor them to the strongest parts of the facial skeleton, which are the facial buttresses. These are the vertical and horizontal pillars of thicker bone that are designed to resist the forces of chewing. You place your 1.5 millimeter mini plates along these buttresses because that's where you get the best quality bone and the best screw hold.
If the maxilla is mobile, what specific bite problem are you likely to see?
A very common finding is an anterior open bite. The force of the impact drives the maxilla downwards and backwards, so the back teeth, the molars, hit each other prematurely, and it props the bite open at the front. The front teeth don't meet.
And that severe malocclusion can only be fixed surgically.
Only by surgically reducing the maxilla back into its correct position.
And we have to reiterate the bleeding risk here. Why are Lefort fractures so prone to heavy bleeding?
Because the force required to create these fractures shatters all those posterior attachments deep in the face. It tears the pterygoid, venous plexus, and branches of the maxillary artery. And even if you get initial control with nasal packing, if the bony fragments are still mobile, the bleeding will just restart. Often, the only way to definitively stop the bleeding is to achieve surgical reduction and fixation, which stabilizes the whole block.
Shay, time for check-in 4.
Check-in question 4. A patient comes in, and you can physically move their entire upper dental arch and palate. The rest of their midface seems stable. They're bleeding from their nose. Which Lefort type is this most likely to be, and what specific anatomical structures must the surgeon rely on for plate fixation?
Os.
This classic presentation is a Lefort eye fracture, the floating palate. For fixation, the surgeon must place the plates along the strong facial buttresses of the maxilla to achieve stable repair.
Key takeaways for section 4. The zygoma is our four-legged stool, and it often needs a delayed assessment after the swelling goes down. Lefort fractures are classified by their height of separation from the skull base, with Lefort III being the most severe.
And fixation for these complex midface fractures relies entirely on plating those strong facial buttresses. All right, section 5. This is where we deal with the really acute sight and life-threatening issues in the upper face. Let's start with orbital fractures.
These often happen along with zygomatic or maxillary fractures, but they can be isolated. The most common spot is the orbital floor, then the medial wall. We use the terms blow out and blow in.
Right. A blowout fracture is the classic one. A sudden increase in pressure inside the orbit from a fist or a baseball causes the very thin bone of the floor to fracture and displace outwards into the maxillary sinus below.
And a blow-in.
A blow-in fracture is the opposite, and it's less common. The bone fragments are pushed inwards, which actually decreases the volume of the orbit.
The immediate critical concern here is muscle entrapment. What does that look like for the patient? What do they experience?
Entrapment is when orbital fat, or sometimes the inferior rectus or inferior oblique muscle itself, gets trapped in the fracture line. The key clinical sign is diplopia, double vision, and a physical restriction of eye movement.
So they can't look up properly?
Exactly. When they try to look up, the entrapped muscle or tissue gets tethered and the eyeball can't move. It's a mechanical problem.
Now let's talk about the specific pediatric emergency you flagged.
Yeah.
The oculocardiac reflex. This requires a really high index of suspicion.
This is a vital concept for you to grasp. In children, entrapment of the inferior rectus muscle, even in what looks like a tiny fracture, can trigger this powerful reflex. It presents as a triad of symptoms: bradycardia, a dangerously slow heart rate nausea, and sometimes syncope or fainting.
What makes it so urgent? Why can't we just wait and see?
Because the traction on that trapped muscle is cutting off its own blood supply. It's becoming ischemic. You can get irreversible muscle necrosis, muscle death, within a matter of hours. This patient needs to go to the operating room immediately to have that tissue released.
And the appearance on the CT scan in children can be really misleading.
It's a huge clinical trap. This is our white eye blowout trapdoor anchor. In children, the bone is more flexible. It can act like a trapdoor. It hinges open, traps the muscle, and then snaps shut again.
So on the CT scan, the fracture can look undisplaced or only minimally displaced.
Exactly. And crucially, these children often present with no subconjunctival hemorrhage, no blood on the white of the eye, because the bone didn't shatter, it just flexed. That's why it's called the white eye blowout. The lack of external signs is the trap.
Long term, if an orbital fracture isn't managed correctly, the change in the orbital volume can lead to visible deformities.
That's right. Two things can happen: hypoglobus, where the eyeball sinks downwards and sits lower than the other eye, and enophthalmos, where the eyeball sinks backwards into the socket because the total volume of the orbit has increased.
And these might not be obvious right away.
They often only become apparent 2 to 4 weeks after the injury, once all that initial swelling has finally gone down.
So if a patient comes back with persistent double vision or a sunken eye, surgery is indicated. What materials do you use to reconstruct the orbital floor?
You need to bridge the defect and restore the orbital volume. We often use preformed or custom patient-specific titanium mesh implants. In cases of a really large defect, sometimes an autologous cranial bone graft is used.
Okay, now we shift to the most immediate time-critical emergency, retrobulbar hemorrhage. This is our ticking clock anchor.
This is absolutely non-negotiable. If you suspect it, you act. You don't wait for a scan. Acute bleeding behind the eyeball causes the pressure inside the bony orbit to skyrocket.
And when that pressure gets too high,
when the intraorbital pressure exceeds the perfusion pressure of the central retinal artery, the artery collapses. It chokes off the blood supply to the optic nerve. The result is ischemia and permanent blindness.
what are the specific clinical signs that should trigger immediate action?
It's a classic presentation. Tense proptosis. The eyeball is bulging forward and feels rock hard to the touch. The patient will complain of severe increasing pain. You'll see you make a cut laterally through the corner of the eyelids, and then you specifically cut the inferior limb of that tendon, that's the cantholysis. This allows the whole orbital contents to bulge forwards, immediately decompressing the orbit and restoring blood flow to the optic nerve. It has to happen within minutes.
Is there any role for medication here?
Yes, as an adjunct to the surgical decompression. We give drugs that reduce intraocular pressure and systemic fluid like mannitol, acetazolamide, and high-dose steroids to reduce swelling, but they are no substitute for the canthotomy.
Finally, let's move to the top of the face. Frontal sinus fractures. These imply a massive amount of force.
Yes, if the frontal sinus is broken, you have to assume there could be an intracranial injury until you prove otherwise. Classification is key. Is it the anterior table, the posterior table, or both? And is the frontonasal duct injured?
We talked about the risk of a dural tear. How do you confirm that clear fluid leaking from the nose is actually CSF?
The definitive test is the beta $2 transferrin assay. It's a lab test on the fluid that is highly specific for CSF protein.
The management goal for these fractures is to achieve a safe sinus. What does that mean in practice?
A safe sinus is one that is structurally sound, protects the brain, has normal function, and won't lead to long-term complications. If a fracture is minimally displaced, less than 2 millimeters, we can often manage it conservatively with observation.
So when do you operate?
The indications for surgery are a significant cosmetic deformity of the forehead from an anterior table fracture, obstruction of that frontonasal duct, which will lead to a mucocele.
A pocket of trapped mucus.
Right. Or, most seriously, a significantly displaced posterior table fracture.
And if the posterior table is involved, it becomes a joint case with neurosurgery.
It has to be. The standard management involves removing the shattered posterior table, a procedure called cranialization, where the sinus becomes part of the anterior cranial fossa. Then the sinus lining is completely stripped out, and the cavity is sealed off obliteration, and the frontonasal duct is occluded.
And there's an extra layer of protection used.
Yes, a vascularized pericranial flap, which is a layer of tissue from the scalp, is often rotated down to create an extra barrier between the nasal cavity and the brain to prevent ascending infections like meningitis.
And follow-up is long-term.
Absolutely. Because of the risk of delayed complications like mucocele or Pott's puffy tumor, which is an osteomyelitis of the frontal bone, a follow-up CT scan at 6 months to a year is essential.
Time for our 5th check-in.
Case study prompt 5. A 15-year-old hockey player gets hit in the eye with a puck. His vision is fine, his eye looks normal externally, but he's complaining of being really nauseous, and on assessment, his pulse has dropped to 45 beats per minute. What specific subtle fracture is causing these systemic symptoms, and what is driving the immediate surgical urgency?
Boss.
This is the classic presentation of a white eye blowout fracture causing the oculocardiac reflex. The immediate surgical urgency is driven by the need to release that entrapped inferior rectus muscle to prevent irreversible muscle necrosis, which can happen within hours.
Key takeaways for Section 5. The white-eye trapdoor fracture in children is a surgical emergency because of the oculocardiac reflex. Retrobulbar hemorrhage is a pressure emergency requiring immediate lateral canthotomy.
And the goal of frontal sinus management is creating a safe sinus, which often requires advanced neurosurgical techniques like cranialization for posterior table injuries.
All right, we're on the home stretch. We're going to finish by covering soft tissue repair, the last of the complex fracture patterns, and dental trauma.
So, for soft tissue injuries, the blood supply to the face is incredible, which is great for healing, but the cosmetic stakes are high, so the repair has to be meticulous. What are the key principles?
The principles are straightforward. Clean the wound meticulously and close it in layers. The deep layers get resorbable sutures to take all the tension off the skin. The superficial skin layer gets very fine, non-resorbable sutures like 5-0 or 6-0 to leave the minimal possible scar.
What about really dirty wounds? The source mentions this concept of a dirt tattoo. Yes, if a wound is contaminated with road grit, gravel, asphalt, you have to gently but thoroughly scrub it with a soft brush and saline. If you don't get all those tiny particles out, they become permanently embedded in the scar as it heals, creating a dark, ugly dirt tattoo that's incredibly difficult to fix later.
Okay, let's talk about the nerve and duct injuries. The facial nerve injury guidance is really specific.
Yes, and this is a great anchor for you to remember, the canthus line anchor. The guideline is that a laceration to a facial nerve branch that is lateral to a vertical line drawn down from the lateral canthus of the eye is considered technically repairable.
Why that line specifically?
Because lateral to that line, the nerve branches are larger and run more parallel. Medial to that line, they've branched into a very fine, complex network, the pes and serenus, and they're generally too small to repair. The repair itself requires high magnification, usually an operating microscope, and a general anesthetic.
And the parotid duct, Stenson's duct. How do you know for sure if it's been cut?
First, you look at the location. The landmark for the duct is the middle third of a line from the tragus of the ear to the middle of the upper lip. If a cut crosses that line, you have to be suspicious. To confirm it, you can inject methylene blue dye into the duct opening, which is inside the cheek near the upper second molar. If blue dye leaks out of the wound, the duct is severed.
And the repair is just as delicate.
It has to be repaired over a fine cannula or stent to keep it open, again, under high magnification.
What about the high-risk scenario of bites, human or animal?
These are considered highly contaminated wounds. They need to be cleaned thoroughly. And while we generally aim for primary closure on the face, prophylactic broad-spectrum antibiotics are mandatory because of the huge risk of polymicrobial infection. For human bites, it's also sensible to do HIV and hepatitis serology.
Shifting back to bone, isolated nasal fractures are common and often assessed later. But the really serious version is the nasoethmoidal or NOE fracture.
The NOE complex involves the very fine bones between the orbits and the nose. It takes a huge amount of force to fracture it. And the clinical signs are unique. You get a depressed nasal bridge, an upturned nasal tip, the so-called piggy nose, and massive bruising around the eyes. But the key sign is telecanthus.
Explain the difference between telecanthus and hypertelorism.
Hypertelorism is when the eyes themselves, the orbits, are too far apart. That's usually congenital. Telecanthus is when the distance between the inner corners of the eyelids is too wide, but the distance between the pupils is normal.
And in trauma, what causes that?
It happens because the force shatters the ethmoid bones where the medial canthal ligament attaches. That ligament gets pulled outwards with the bone fragment, widening the space between the eyes.
So the surgical challenge isn't just fixing the bone.
No, not at all. The absolute key to a successful NOE repair and a good cosmetic result is accurately repositioning and fixing that medial canthal ligament attachment. It often requires passing wires from one side to the other through the nose to pull the whole complex back to the midline. If you miss that, the patient has permanent telecanthus.
Finally, we get to the panfacial fractures, the ultimate surgical puzzle, involving all three facial thirds. What's the fundamental prerequisite before you can even start the repair?
First, the patient has to be systemically stable, but even then, the repair itself usually has to be delayed for about a week. You need to wait for the massive swelling to subside so you can actually see and feel the bony anatomy and reduce the fragments accurately. The 3D reformatted CT is absolutely essential for planning this.
And the management anchor for panfacial trauma is all about the sequence. You can't just fix what's closest. What's the strategy?
The standard, most common sequence is top-down and outside-in. The logic is to reestablish the stable outer framework of the face first, and then build the inner structures onto that stable frame.
Okay, break down that sequence for me.
Step 1. You start at the top and the outside. You fix the most stable reference points, the frontal bone and the zygomatic arches. This reestablishes the width of the face.
Okay.
Step 2, you work your way inwards. You fix the orbital rims and the central NOE complex, using your newly fixed arches as a guide. Step 3, you reconstruct the mandible. You build the foundation.
And the maxilla is last?
The maxilla and the orbital floors are last. You fix the maxilla last because you need to use the now stable, reconstructed mandible as your guide to put the teeth back into the correct occlusion.
That makes perfect sense.
Oh.
But it brings up the airway issue during surgery. How can the surgeon possibly check the bite if the patient has an endotracheal tube in their mouth?
They can't. An oral ET tube makes it impossible to check the occlusion. So for these complex panfacial repairs, you need a surgical airway. That's either a formal tracheostomy or, increasingly, the less invasive submental intubation technique. That's where the ET tube is passed through a small incision under the chin. It moves the tube completely out of the mouth and the operative field, so the surgeon can freely close the jaw and check the bite throughout the procedure.
Our very last category, dental trauma. We have to reiterate the critical rule for avulsed or knocked out teeth.
Yes. For a primary, deciduous, or baby tooth that's knocked out, you do not reimplant it. You risk damaging the permanent tooth bud that's developing underneath it.
But for an adult, permanent tooth.
For an adult tooth, immediate reimplantation is best. If that's not possible, the tooth must be stored in a suitable medium to keep the cells on the root surface alive. Milk is ideal, but saliva or normal saline are also acceptable.
And once it's reimplanted, what's the aftercare?
A reimplanted tooth needs to be splinted for about 2 weeks, usually with a fine wire and composite resin. A tooth that's just displaced or luxated needs to be repositioned and splinted for longer, about 4 weeks. And all of these injuries need long-term follow-up with a dentist.
Okay, time for our final check-in, check-in 6.
Check-in question 6. A patient has a severe nasothoidal fracture, and they clearly have telecanthus. What is the key functional structure that has been displaced to cause this, and what specific surgical goal must be achieved to correct the deformity?
Oz.
The displaced structure is the medial canthal ligament attachment. The critical surgical goal is the accurate repositioning and fixation of that ligament, often using transnasal wiring. If you miss that link between the sign and the structure, just review section 6.2.
Our detailed takeaways for this final section. Soft tissue repair must focus on preventing that dirt tattoo. Facial nerve injuries lateral to the lateral canthus are generally considered repairable.
The nasopharyngeal fractures are defined by telecanthus, and the repair hinges on repositioning the medial canthal ligament. And panfacial repair uses that crucial top-down, outside-in sequence, often needing a cemental intubation to allow for checking the bite. So we have spent a good amount of time today interpreting and trying to structure this incredibly complex topic of maxillofacial trauma. We've gone from the ABCs and the language of injury right through to the detailed management of the jaw, the midface, and the orbit.
We tried to secure your mental architecture with those anchors.
Yeah.
The Jenga tower collapse, the zygoma stool, the Lafort levels, the ticking clock of retrobulbar hemorrhage, and that all-important sequencing of panfacial repair. The goal was always to give you the context, the why, behind these high-stakes decisions.
And it's so important to remember that success in this field really hinges on that structured, systematic assessment. The final diagnosis is always a blend of clinical acuity. Being able to feel that subtle step deformity under the swelling, or picking up on that patient's comment about their altered occlusion, combined with the detailed roadmap you get from the gold standard CT scan.
Now, for our final provocative thought for you to take away, and it builds directly on those contrasting timelines we discussed in Section 5. I want you to think about the fundamental difference between the zygomatic bone and the pediatric orbital floor.
The chapter tells us that the zygoma often requires a delayed assessment, maybe a week later, because the consequence of waiting is primarily cosmetic, and you get a better assessment when the swelling is down.
But in contrast, the pediatric orbital floor, which might look minimally displaced on a scan, that white-eye trapdoor, requires immediate intervention within hours.
So consider the core difference in consequence. For the zygoma, the risk is cosmetic deformity or mild functional loss. For the pediatric orbital floor, the risk is catastrophic muscle death or a life-threatening reflex bradycardia.
And it's that profound difference in potential consequence cosmetic loss versus tissue death that dictates such radically different management timelines for two structures that are literally right next to each other in the face.
That juxtaposition, I think, really highlights the nuance of surgical priority. Thank you for joining us on this deep dive. We hope this structure helps you in your revision, and we absolutely encourage you to go back to the foundational Baily and Love text for the full, detailed context.
We'll see you next time.